My name is Deacon Raymond Fuller Jr. I'm a member of Morning Star Baptist Church in Boston, Massachusetts. And I too, as it's been said this morning, am a survivor, but I'd like to change that to a warrior. Getting up here is not easy for me. It will come easier as I go on. I'd like to say thank you to Mr. Farrington for this 10th annual African American Prostate Cancer Disparity Summit. This is history for me. This is going to be a part of my life and my kids' life because I will always remember this moment as long as I live. I'd also like to thank all the doctors out here who's in the forefront of this dreadful disease, fighting for our survival. You are the instrument. When I was diagnosed, I didn't know what I was going to say, but being a deacon in the church, and I'm not going to take too long, I became more familiar with how God operates because I was traumatized by the word cancer. A family, how are they going to survive? And what am I going to do? But late in the midnight hour, that word cancer became null and void to me because I found out that there is a greater and a more important person, and that's God Almighty, who is the head of all. So with that, I'd like to introduce the next speaker of the hour. He is a board-certified urologist and a medical director of urology of medicine affairs at Genomic Health for the launch of Oncotype DX prostate cancer tests. Dr. Dees leads physicians, educating efforts, and the development of the company's prostate cancer test study. I present to some and introduce to others Dr. Dees.
Thank you and good morning. First of all, I'd like to congratulate PHEN on their 10-year anniversary and thank Mr. Farrington for the opportunity to speak here. This is my second year in a row, so I feel like I'm coming back to some familiar faces. And I will fill you in on some of the progress that we've made in the year since we were here in Washington, D.C. last year. So I don't know what just happened there. But I'm going to be talking on the role of genomics in the management of newly diagnosed low-risk prostate cancer with a focus on African American men. A couple of things I'd like to say before we get started is that we've had some medical oncologists speak in the room. And I think that for urologists who work in prostate cancer, breast cancer is our role model. Breast cancer is sort of our poster child because in the research, both in the diagnostic and the therapeutic advances in breast cancer have surpassed what we've seen in prostate cancer. I mean, I personally feel we're about 20 to 25 years behind breast cancer. And if you just think about it, in 1990 or in the late 80s, when a man came in for evaluation of his prostate, what did we do? We did a rectal examination, we did a PSA, and we did a biopsy and looked at the Gleason score. So if you fast forward to 2014, what do we do now? We do a PSA, we do a rectal examination, we do a biopsy, and we look at the Gleason score. So we have not seen the incremental advance in the diagnostics, the BRCA genes, the HER2, the receptor genes that have been implemented in breast cancer, not only to stratify the risk women face, but to help guide individualized treatment decisions. Dr. Carter, in his last comment, mentioned that we need to move on from looking at groups of men, whether you're 50 or younger or 65 or older, and start to individualize treatment, and I'm going to speak about that a little bit today. The one thing, so I've heard a lot of people say they're survivors, and they are now sort of switching that term to warrior. So not being a survivor of prostate cancer, I can't really call myself a warrior, but I will say that I'd like to regard myself as a soldier that works every day to educate men, physicians about prostate cancer and about some of the newer diagnostic tools and some of the newer therapeutic avenues that are open to them. But I'll go back again to my last year when I was finishing up my urology training. I was chief resident of urology at Washington University in St. Louis, and had the pleasure of having a visiting professor named Willett Whitmore come to St. Louis from New York City. He was the chief at Memorial Sloan Kettering and arguably one of the great names in prostate cancer. And we were walking down the hallway to his lecture, and we were discussing prostate cancer. And at that time, he said, you know, there are two unanswered questions in prostate cancer. We're talking about in the early 1980s now. And he said, the pivotal questions that we don't have answers for in prostate cancer are, first of all, is cure possible for those men who need it? Okay? And is it needed in those men where it's possible? Okay? And again, he sort of addressed this whole issue of overtreatment and undertreatment. And are we actually treating the right patients? Are we treating the patients that need therapy? So we've heard a lot today about PSA controversy, PSA confusion, and some of the other things. And I'm just going to recap some of the things that we saw. If we could see the first slide. A little bit of background about the company. Genomic Health is a company that's based in San Francisco. We've been in business about 12 years and brought the first product to market 10 years ago in 2004, the Oncotype breast cancer assay for women diagnosed with invasive breast cancer. And it has actually revolutionized the risk assessment and treatment of women with invasive breast cancer. And I think that the medical oncologists in the room would agree that there's not a single woman diagnosed with invasive breast cancer today who does not get a genetic test, a molecular analysis of that tumor to guide their treatment decisions. And there is not one man in this room with prostate cancer who can say that they've had the benefit of that kind of risk assessment or analysis. So that's our vision for prostate, to catch up with where breast was 10 years ago. The one thing that I want to focus on is that the company has a very unique approach to the laboratory test development, and that is we step back, look at the disease, and ask what is the critical unanswered question. So in breast cancer, it was, do I need chemotherapy? Can you go back, please? And in prostate cancer, that question is very different. Do I need immediate treatment? In other words, we saw the graphs where men live a very, very long time with prostate cancer and then suddenly drop off at 17 or 20 years. But many men actually have sort of indolent forms of prostate cancer, and this is true for the African American as well as the Caucasian American community. But we don't have the proper tools today to figure out who actually would be safely watched under a program of observation or surveillance, and who has the type of aggressive cancer that we heard about here today that you really sort of need to throw the kitchen sink at for the best outcomes. Next. We heard a little bit about the United States Preventive Task Force report, where the PSA report card got a D. And again, the emphasis on getting a D is not only do you not do good, but you actually end up harming the people. And I will agree with everyone who spoke today that it is not the PSA's fault. The PSA is a fabulous test. It's a great test when used properly. All the harm comes from what the PSA triggered in terms of kind of knee-jerk reflex responses, immediate biopsy, if cancer is found, immediate therapy. Again, because we don't have the tools to properly stratify patients. Next. So we heard a little bit about the task force recommended against, just made a flat recommendation against screening, and I'm certainly aligned with those who feel that that's gone a little bit too far in one direction, and we need to bring some balance to the recommendation. And the pendulum, I think, is shifting back a little bit. The AUA came out with their response, and again, they sort of used this age-targeted screening for men between 55 and 69. The problem is, as Dr. Cooney mentioned, there's a lot of men who present with prostate cancer that the AUA would suggest that you don't screen. And again, one of the other criticisms is that the AUA did not address specifically the issues for high-risk men, including African-American men. Next. So we had the PSA controversy, okay? Now we have the treatment controversy, to treat or not to treat, okay? We've heard about some of the trials that have been published. This is sort of a landmark trial called the PIVOT trial, which was published in the most prestigious medical journal, made the cover article of the New England Journal of Medicine. And the title was Radical Prostatectomy versus Observation for Localized Prostate Cancer, and looked at the outcomes of men who were randomized to have observation, in other words, no intervention at all, just follow them along, versus radical prostatectomy. Next. And when the results came out, the media was all over this. CNN, Fox, the Washington Post, USA Today, and the New York Times. And this is the headline that you saw in the newspaper. Prostate cancer surgery shows no benefit for many men. Observation is as effective a treatment as radical prostatectomy. Okay, so now this confused the audience even more, and confused the medical community some more, because first of all, for years we've been pushing for early diagnosis and aggressive treatment. Now we've got this landmark article in the most prestigious journal that says, wait a second, if you do nothing in prostate cancer, it is as effective as radical prostatectomy. But here's what was lost and was not picked up by the media. Next. Is the actual study results were not accurately reported. Now, in this article, risk stratification between low risk and high risk was very, very crude. They used a PSA cutoff of 10 to stratify risk. In other words, if your PSA was under 10, irregardless of your Gleason score, you were considered low risk. If your PSA was over 10, it was high risk. But again, but look at the results, okay? If you had a PSA under 10, then radical prostatectomy did not reduce all-cause mortality. It didn't affect how long you lived, okay? And there was no difference between prostate cancer-specific mortality, whether you had radical prostatectomy or observation. So in this so-called low-risk men, there was not much benefit to any intervention. But look at what happens if you have high-risk disease, in this study just defined as a PSA of over 10, okay? For men with high-risk disease, there was a significant reduction in all-cause mortality. Men who were operated on lived longer for all causes. okay? And look at the reduction, the relative reduction in prostate cancer-specific mortality. In other words, your risk of dying of prostate cancer for an individual was reduced by over 60%. So again, that message was unfortunately lost when the media rolled out this study. Next. Now, the third controversy, which we didn't talk about yet today, is the Gleason 6 controversy, okay? And the Gleason 6 controversy asks the question, is Gleason 6 really prostate cancer, or is it some other proliferative cellular disorder, not like BPH, but something different, but maybe not malignant, okay? And where does this come from? Well, this comes from this landmark paper from Hopkins that was published by Dr. Jonathan Epstein, who is arguably the world's foremost expert pathologist in prostate cancer. So what he did is he went and he published the results in this article, is he looked at four series of men at different universities in the US. And in this series of men who had undergone radical prostatectomy, he had access to 14,000 radical prostatectomy specimens. Each of those specimens was then looked at for Gleason score and the extent of the disease, and he was able, in this 14,000 series of men with radical prostatectomy, for men who had Gleason 6 disease that was confined to the prostate, what we call organ-confined disease, there was not a single case of metastases to the pelvic lymph nodes, okay? Not one, okay? He then concludes this article by saying, in his opinion, pure Gleason 6 cancer does not have metastatic potential. I mean, think about that, okay? So if you have Gleason 6 cancer, the question then comes up, what is the proper treatment? Is observation following the right treatment, or do you benefit from aggressive therapy? And we'll answer some of that. Next. So, and then the final question is, what about PCA in African American men? And as the t-shirt says, real men don't fear the finger, okay? And this reminded me when I saw this, when I put this slide together, is that a little comment on fear is always remember what Winston Churchill said, is that we have nothing to fear but fear itself, okay? So, but what about prostate cancer in African American men? Next. We've seen some of these data. These are the facts, okay? And this is in the PSA era. So this is not historical data from the 70s, the 60s, or the 80s. These are in the PSA era when PSA was available in the 90s and up to the early 21st century. And what you see is, again, demonstrated what we've heard, is that if you look at Caucasian men and African American men, African American have 100% higher incidence, in other words, double the incidence of prostate cancer than in their Caucasian counterparts, okay? And we saw that this line is going down, okay? But look, this line is also going down, okay? So when you look at this endpoint, you're still having a 100% higher incidence of cancer in African American men. Now let's look at the outcome data next. So we've made a big push for early diagnosis and early intervention. So what about men who present with organ-confined disease? So this is men who are discovered to have prostate cancer, and there's no sign either by rectal examination, ultrasound, CAT scan, whatever mark that you want to do, that they have organ-confined disease, and then they get treated. What's the outcome? And again, you can see that even for men who are diagnosed with organ-confined disease, this Kaplan-Meier line for African American men separates. There is a difference. This has not reached formal statistical significance, but certainly there is a difference. Now, what about men with advanced disease? Next. Look at this difference, okay? Now it is significant, not only is the difference large, but it's statistically significant. So again, raises the question, is prostate cancer a different disease in African American men or men of African descent, wherever they may be, compared to Caucasian or their European counterparts? Next. So these are the outstanding questions about that we yet are trying or struggling to answer with for African American with prostate cancer. Okay, are these racial differences due to distinct biologic differences, inherited trait? Okay, germline genetic changes that are inherited and go from generation to generation. And we've heard this morning that there is some evidence certainly to support that. What about the environmental factors? You know, we've heard about smoking and diet and those kind of things. But you know, I couldn't help, I flew into Baltimore yesterday because I had a meeting in Baltimore, and then kind of got a ride down to Washington, D.C. yesterday afternoon. And as you're driving through the countryside, you kind of look at the countryside and you look at the horse country in Virginia, and you think, and then you look at the inner city in Baltimore or Washington, and then you have to ask yourself, are people exposed to the same toxin, the environmental toxin? Are they breathing the same air? Are they eating the same food, drinking the same water? So these are, again, our unanswered questions. What about socioeconomic differences, including differences in education? What role do they play? And then access to care. I mean, it's definitely, you know, it's not a mystery that access to care is different. Unemployment rates are higher, especially in the younger African American men. So what are these effects? What about the culture inhibition, shame, denial, not going to the doctor, not wanting to face the question, the fear of the finger, okay? And then the fear of treatment, and then the fear of the related side effects. So, you know, if you ask these questions, there's thought leaders with opinions on both sides of the fence. We heard Dr. Jim Moeller mention before. He's head of the NCCN, and he's up at Roswell Park. And so he's done a lot of work on this, and he really feels that it's mostly driven by social, cultural, socioeconomic factors, and not by genetic factors. So, but you know, we're doing work in that space, so we'll have some answers very, very soon. Next. Now, so you just go into the doctor, and we heard some of the survivors, or rather the warriors, say that when the doctor says you have cancer, everything else goes blank. You have, you know, and he's talking, but you're not listening. So then you go home and do your research, and then you come up with your treatment options, okay? So you've got, these are the decisions to be made for a man with low-risk prostate cancer, okay? The doctor says you've got cancer, but it appears to be low risk. So you can have surgery, okay, radical prostatectomy, open or robotic, or you can have some sort of cryotherapy or hormonal therapy, external beam therapy, radiation therapy, brachytherapy, or active surveillance. So you're sort of dump this literature on you and say, go read about this, go talk to your family, go talk to your friends, call me with any questions, and I'll help you get through it. So what you need is guidance, okay? So if you need guidance, the natural place to go is the guidelines, okay? Because the guidelines are put together by very, very smart guys to help guide treatment decisions. Next. So if you go to the guidelines, and this is the current 2014 NCCN Guidelines for men with low-risk prostate cancer, and Tom Farrington sits on the board that helped put together these guidelines and publish these guidelines. What you see is that if you have a less than 10-year life expectancy, you shouldn't do anything if you have low-risk prostate cancer. And I fully agree with that, because the odds of dying something other than prostate cancer certainly far outweigh the risk of dying of low-risk prostate cancer if you have a limited life expectancy from other causes. But what if you have over a 10-year life expectancy? Well, what the NCCN says, here's our guidance. You can have active surveillance and just sort of monitor the cancer. You can have radiation of whatever flavor radiation your doctor likes, with or without hormonal therapy. Or you can have some sort of radical prostatectomy. So you said, okay, But again, Dr. Carter said, you know, we have to get to the point where we're starting to individualize treatment recommendations. But what the NCCN says is these are your treatment options, and the NCCN goes one step further, and the NCCN says that between these options or among these options, there is no evidence that any of these treatment options, active surveillance, radiation, or surgery, prolongs life or improves your chances of survival. They're equivalent therapies. So if I'm a guy and you're telling me that active surveillance is just as good as having radiation and radical prostatectomy, I'm going to start to think about active surveillance because of that quality of life that we heard talked about, okay? I mean, if you're afraid of erectile dysfunction or urinary incontinence, the lowest rates of erectile dysfunction and incontinence are arguably with active surveillance. Next. So the question comes up, though, is if you talk about active surveillance, is it safe? Well, how do we measure safety in active surveillance? Well, there's a couple of ways to do it. One is to look at what are your chances of dying of prostate cancer if you have low-risk prostate cancer and you go on active surveillance. So here's about 7 large series worldwide: Japan, the UK, Europe, North America. And what you see is that for men who go on active surveillance, in other words, carefully, intelligently monitoring the cancer, the likelihood of dying of prostate cancer is under 1%. Cancer-specific survival, in other words, being alive with the cancer, is 99.4%. So one thing that you can say is that men who do choose active surveillance will not die of prostate cancer while they're on surveillance. Okay? You can safely say that. But the other question is, how do you end up doing on surveillance? Because part of surveillance is to find higher risk disease so that when you do find it, you can come off it. So what percentage of men actually stay on surveillance and what percentage come off? Well, that's all over the place, okay? It's around 16% in Miami, but it's 50% at UCSF, okay? Well, and that is because they select differently, they follow men differently. But again, it tells you that active surveillance is not the perfect treatment for everybody, because somewhere between 1/3 and 1/2 of men starting active surveillance will be found to have higher risk disease and then go on to have intervention, surgery, radiation, or hormonal therapy. So the challenge to active surveillance is to find these guys early, to select better up front so that you can select men who are not going to progress for your active surveillance program. Next. And then what about the long-term safety of active surveillance? Well, this is from the Klotz report group in Toronto, who has the world's largest and longest active surveillance cohort. Men followed for 14 years. Look at this cancer-specific survival. It's almost flat, okay? I mean, I think that, you know, this almost looks like it's not a malignant disease. And again, goes back to that question, is Gleason 6 really, does it have metastatic potential? But, you know, I always, when I'm talking to men, especially groups of men with prostate cancer, I always focus on this slide, okay? Because the thing that's lost in the conversation is that the #1 killer of men with prostate cancer is heart disease, okay? It is not prostate cancer, it's heart disease. And we talk a lot about lifestyle changes, exercise programs, avoiding red meat, eating more lycopenes, you know, megavitamins and these kind of things, omega-3 and these kind of things that are supposed to impact prostate cancer. And whether they do or not remains to be seen. But one thing is true, is a prostate healthy diet is a heart healthy diet. And you may not impact your chance of either getting prostate cancer or the progression of the cancer, but one thing you will impact is your length of life, because a heart healthy diet will allow you to live longer. Now, these are the statistics, and this is across the board, is that 50% of men are diagnosed with low-risk prostate cancer based on PSA screening. Their lifetime likelihood of death is 3%. But what happens? 90% get radiation or surgery. and 10% go on surveillance. Now, these numbers have moved a little bit. It's probably closer to 20/80. But again, look at this. This is your risk of dying of prostate cancer, and these are the guys getting treated, okay? This is kind of like saying you're buying a high-performance car that comes with, you know, a good warranty, and the manufacturer recommends that you change the oil every 6,000 miles. But instead of changing the oil every 6,000 miles and monitoring the engine, you go in and you get a new engine put in every 6 months. You know, you get a complete engine rebuild. Well, we wouldn't do that for our cars, but we're doing that ourselves. And part of this is driven by, next, the fact that the limitation of our diagnostic techniques, because everyone in this room who's had prostate cancer has had it diagnosed by what's called a TRUST biopsy, which is a transrectal ultrasound-guided biopsy, what we refer to as a random biopsy. So the doctor looks at the prostate under the ultrasound guidance and takes 12 samples, 6 from each side, and then sends it to the pathologist for diagnosis. So the one thing that we don't emphasize to our patients is the inaccuracy of TRUST biopsy, okay? So this is a very interesting series that was published last year from South America that looked at over 1,000 men who underwent radical prostatectomy because they were told they had prostate cancer. Out of this 1,300 men, 266 of these guys out of the 12 cores had one core positive for prostate cancer, and most of it was Gleason 6. 85% had one core of Gleason 6. Now, we just saw some data that Gleason 6 may not have malignant potential, okay? So it raises the question, well, then why are you having a radical prostatectomy? Well, here's the answer. Okay, because when the prostate was removed and compared to the biopsy pathology, 45% of the time, nearly half the time, the pathology in the prostate that was removed was different than what was diagnosed in the biopsy. The limitation of our transrectal biopsy. Next. I'll illustrate that here. This is what the prostate looks like when the pathologist cuts across it after it's removed. And you've got a lesion here, you've got a lesion here, and you've got a lesion here. So this patient now has a PSA of 5.8, and he's told he needs a biopsy. So he goes to see his urologist, and the urologist does a biopsy. Next. And this is the biopsy report. It comes back negative, no cancer seen. Okay? And he goes back to the urologist, and the urologist says, I've got great news for you. You don't have any cancer. We did 12 biopsies, and you know, you can go on with your life and move on, okay? But it is just as likely that the biopsy would have picked up, next, this, okay? Because the needles just happened to hit randomly this area of the prostate. Now the diagnosis is you have Gleason 6 tumor, it's low risk, you don't need anything, we're gonna watch you on surveillance. Or, next, he could have had this biopsy, or next, this biopsy, okay? Now the discussion is very, very different because now you have Gleason 8 disease, and the discussion is about aggressive therapy, combination therapy, hormonal therapy, radiation, etc., okay? And it's all the same prostate, but it's due to the random nature of the biopsy because we cannot see the tumor, we cannot feel the tumor, so we're just sticking needles blindly. And each one of these biopsy cores samples less than 1/2 of 1% of the total prostate tissue, okay? So that's the limitation. What Genomic Health set out to do 5 years ago is to say, can we look at this little piece of cancer in this tissue and see if there's a signal from the genetic makeup of this tumor that's in this prostate that would tell us whether you are really looking at low-risk prostate cancer or there is some lurking high-risk disease somewhere else. Because if it really is a disease that affects the entire prostate, those cells are talking to each other, there should be a signal detected. Next. Next. So just to show you that I'm not blowing smoke about the random nature of this biopsy, this is the likelihood of a Gleason 6 needle biopsy agreeing with the radical prostatectomy across huge series, okay? Across the board, there's about 30% agreement. So 1 in 3, the radical prostatectomy doesn't agree with the biopsy. It's even worse for Gleason 3+4. Next. When you look at Gleason 3+4 degrees in agreement with radical prostatectomy, about 25% of these patients who have Gleason 3+4 actually have Gleason 3+3. They're downgraded at surgery. And about 25% are upgraded to Gleason 4+3 or 4+4. So for Gleason 3+4, when I'm talking to a patient and I say, you've got Gleason 3+4 on this biopsy, I tell them it's going to be wrong half the time. So it's very difficult to make that individualized treatment decision based on the limitations of our current diagnostic techniques. Next. So what about genetics and genomics and their role in this disease? Where are we? How can we catch up with breast cancer? Well, we heard a little bit about genetics, and genetics is the study of inherited traits. Next. And this is just to highlight the differences between genetics and genomics. So genetics, again, is we heard about the BRCA gene. So these are inherited traits. And genomics focuses on the expression and interaction of hundreds and thousands of genes within the individual cell. Okay? So they sound alike, but they look at different things. Next. So this is the current biomarker landscape. When the gentleman asked about the negative biopsy, I did mention one of these tests. Okay, this is the Confirm DX test. So these tests up here are what we have at our disposal. They're all relatively new within the last two, perhaps 3 years. A PSA we know about, the Confirm MDX test, is a test that if you have a suspicion that you have prostate cancer, but the biopsy's negative, just like I showed on that cartoon before, it could be negative, your doctor will send the negative biopsy cores into the company. They're based in Irvine, California, and they will analyze each of those negative biopsy cores to see if there's a detectable signal called DNA methylation that suggests that there's cancer lurking nearby and was just missed, okay? Oncotype DX is the test I'm going to be talking about. That's the one that I work on. Prolaris is, again, a molecular assay, a genomic assay that's available both at the biopsy setting as well as in following radical prostatectomy to look at the aggressiveness of the disease, and especially in radical prostatectomy, to see if you had the kind of disease that's destined to come back and whether you should have radiation or some other therapy in addition to the radical once you've recovered from it. Decipher, again, is a test that looks at the aggressiveness in high-risk prostate cancer in the post-prostatectomy setting, again, designed to answer that question, should you have additional therapy on top of the surgery because you're at a high risk of disease recurrence or failure. Circulating tumor cells are sort of looked at in prostate cancer to see if we can sort of develop some prognostic tests and also assess the treatment response by measuring or counting the number of tumor cells that are in circulation. And then these are a slew of other tests that are in development. Next. So the Oncotype DX prostate cancer assay, which I've worked on and in the development and the launch, is a multi-gene test based that looks at the gene expression of 17 genes within the prostate cancer itself to determine whether it's an indolent or an aggressive cancer. It is strictly for men with low risk features at biopsy, because if you have high risk features at biopsy, we know you need to get aggressive therapy. And then why do the test? As Dr. Carter says, we need to start to individualize treatment. And the more we know, the better treatments we can recommend. Next. These are the genes, and these are not going to mean much to most people in the audience. They're difficult for me. Next. There's some control genes, and then next. But what we found is that when you look at these families of genes and you put them together in an algorithm, they're much more predictive than looking at individual genes, okay? And one thing that I do want to point out is that some of these genes, when they're overexpressed, are associated with a worse outcome. These are called oncogenes. They drive the aggressiveness of the cancer. Some of these genes, when they're overexpressed, are protective, so they're essentially tumor suppressor genes. And the overall outcome is always this tug of war between these oncogenes and the suppressor genes within the cell. Next. Now, we talked about NCCN risk classification, and when you look at a group of men, and this is a group looking at 400 men from the UCSF validation cohort, there were some men who had NCCN very low risk disease and NCCN low risk and then intermediate risk disease. So the question is, we saw that the biopsy is not that accurate. How accurate is it if you start to risk stratify patients? So what we found in this group, group of 400 men, for men who had very low risk features at biopsy and then went on to prostatectomy, their risk of finding high-grade disease of prostatectomy was 15%. That's the average for the group. The average for the low-risk group is 25%, and the average for the intermediate risk group is 45%, so it jumps up significantly. And this is all we can tell patients or counsel patients based on what we know today, because they're in these large buckets, okay? But what happens, look what happens when you look at the genomic profile of these tumors. Next. What you see is that within this group, there are these men, and these are their genomic prostate scores or GPS scores, from very low to very high, where 0 is the best and 100 is the worst. And next, you see the same thing in the low-risk group and in the intermediate risk group. Next. So what tells you is that not only is prostate cancer very different among races, but they're very different even within these highly sort of select groups, the NCCN very low risk and low. So you've got men who appear to have high-grade cancer, but the biologic feature suggests it's very low risk. You have some men who have low risk clinical features up here, but they look like there's a molecular signature or signal there that they're harboring high-risk disease that was just missed at the biopsy someplace else. Next. Now, so remember, each one of us is unique. Next. And this is an example of two guys who present with Gleason 6 disease. And I can tell you, because I know the outcome of their surgery, because they were included in our study, is one of these men was cured of prostate cancer because he had organ-confined Gleason 6 disease. And one of these men went on to develop metastatic disease because at surgery, he had Gleason 8 disease with positive margins. Yet this is their biopsy, and this is what we are currently making treatment recommendations on. And I can't tell these patients apart, and I've asked pathologists to see if they can tell these patients apart, and the answer is no, we can't, because these biopsies look the same. Next. Next. But if you look at their GPS scores, look at the difference. This is the score of the guy who had organ-confined disease, and this is the guy who developed metastatic disease. Next. So next and next. Okay. Now, if you look at these groups of men, and I talked about the NCCN very low and intermediate group, this is all we know based on PSA, Gleason score, and rectal exam. But if we add the molecular information, that GPS or the molecular signature of the tumor, next, what you start to see is some of these guys actually move down into the very low risk, and next, some move up to the high risk, to the high risk because there's a signal there that they're harboring high-risk disease. Next. You'll find that's in the very low-risk group, there are some guys with high-risk disease, and also in the intermediate risk group. So now we can start, next, to risk stratify patients. So now we can sort of make smarter treatment decisions. And if you'll just click twice, where this actually comes into play, go ahead. Go ahead. Again. Okay, so you've got 3 guys coming into you for consultation asking for what to do, how best to manage their prostate cancer. And, you know, they all look the same based on their biopsy and Gleason score, but look at the difference when you combine the genomic score. This is not the guy right here that I would recommend active surveillance, because based on his genomic signature, he's destined to be harboring high-grade disease and fail surgery. So again, that's sort of the outcome. I've run a little bit over. The one thing that I did want to address is that we're very cognizant of the lack of information in the African American population, and we've proactively addressed that. As I discussed with Tom, we are releasing publicly the results of our second validation trial at the ESMO conference in Madrid this weekend. Unfortunately, the release of that information is on the 28th, and the data is embargoed by the Congress until then, so I can't tell you the details. But I can tell you that you will be very impressed with the results. That validation cohort is in the CPDR, the Walter Reed cohort, where nearly 30% of the men are African American. So we will finally have robust data on the genomic, comparing the genomic signature and differences between, in the same cohort of men with equal access to healthcare in the military, the Walter Reed system, in terms of their outcomes. That study also, will revalidate the endpoint of the first study, as well as look at the ability of the GPS score to predict biochemical recurrence. But this is the future, and I think we're all heading in the right direction.